Let me start recording. Okay. So last class, we talked about this phenomena called bulk flow. We reviewed what diffusion was, and we reviewed osmosis. Okay. But now we're going to talk about this new thing, this bulk flow. Remember that was that push-pull. Okay. When we're dealing with the amount of force or pressure that a fluid exerts in our vascular system, we're going to refer to this term called bulk flow, okay? And it's a push-pull, all right, phenomenon. So there's two components to it. There's the push, and then there's the pull. So the hydrostatic is going to be, all right, for all intents and purposes, the push, okay? So when we talk about hydrostatic pressure, we're going to be dealing with a fluid. All right. So there's two components to the hydrostatic pressure when we're talking about our blood vessels. There's the pressure of the fluid inside the vessel, okay? And that's what we're going to refer to that as the blood hydrostatic pressure. All right. So we label it as HP with the subscript of B for the blood, okay? So this is the amount of force or push, all right, that the blood is forcing onto the blood vessel wall. So basically, all right, it is the force being pushed out. All right, so as blood is in your blood vessels, it's pushing outwards. All right, so in this case, when we're talking about the blood hydrostatic pressure, we're going to refer to this term here, filtration. Filtration, okay, is when a fluid is going to exit the capillary and go into the tissue. Okay, it's being filtered out of the blood vessel. All right, so the second one here is the interstitial fluid hydrostatic pressure. Here's the nomenclature, HPIF, subscript IF, which is the interstitial fluid. This is the amount of pressure that the tissue, the fluid in the tissue, is going to put on the outside of the blood vessel wall, okay? So interstitial fluid, how much it's going to be pushing in on the blood vessel? Well, that's virtually zero, okay? Your tissues have virtually no, all right, hydrostatic pressure pushing into the blood vessel. All right, if you do, it's usually in a pathological situation. All right, it could be inflammation, okay, edema, all right, but in most cases for our tissues, that value will be zero. Okay, so that's hydrostatic pressure. The force of the fluid, all right, it's the force exerted by a fluid. All right, so the second part of bulk flow is what we refer to as colloid. When I say colloid, think of proteins. Osmotic, think of water or fluid in this case. Okay? So this is the pull force that we talked about. Remember, bulk flow is push-pull. Okay? This is the pull. So this is the pulling force that's exerted on water, okay? Because think of the proteins as like a magnet. It has an attractive force for fluid, okay? So we have two parts to our colloid osmotic pressure. Similar situation. We have the blood colloid osmotic pressure, okay? COP with the subscript of B for blood, all right? So this is that attractive pulling force that the proteins or the colloid are drawing fluid into the blood vessel. Okay, so in this situation, it promotes reabsorption. So therefore, if you don't remember, reabsorption is when the capillary or the blood vessel is going to pull something from the tissues into the blood vessel. Filtration, it's pushing something out of the blood vessel into the tissues. Reabsorption, it's pulling it from the tissues into the blood vessel. Okay? So you may hear it as oncotic pressure. In fact, that's what I usually refer to it as, all right, is the oncotic pressure. So the other part to the colloid osmotic pressure is our interstitial fluid colloid osmotic pressure, all right, nomenclature with the subscript of IF. All right, so this is the proteins that are pulling, all right, the fluid out of the blood vessel into the interstitial fluid or into the tissues here, okay? So again, this value is going to be very low. Proteins normally are too big to be leaking or getting out of blood vessels. So they're usually trapped in the blood vessels. All right, so we see a very low value for that, usually 0 to 5 millimeters of mercury. So again, you really should not have proteins in the interstitial fluid. The proteins should be staying in the blood vessels. All right, 7%, all right, of your blood plasma, okay, oh, I take that back, 6% of your blood plasma is proteins. All right, questions on that? This is just a review. I talked about this last class. All right, so that's bulk flow. So we're going to add a new equation in how we figure out whether things are filtering from the blood into the tissues or if it's being reabsorbed from the tissues into the blood. So we have this new equation here, okay, called the net filtration pressure, or NFP, okay? So what we're going to do is we're going to take the net hydrostatic pressure, which is our push, all right? And when you see difference, there's subtractions involved. And we're going to subtract the net colloid osmotic pressure from that. So here's our equation, NFP, which is basically the hydrostatic pressure minus the oncotic or the colloid osmotic pressure, okay? And we just learned that there's two components for each of those pressures, right? For the hydrostatic pressure, we have the pressure that's being exerted on the blood vessel wall from the inside, pushing out, and then we have the pressure being exerted on the blood vessel wall from the outside, pushing in, okay? And then we take the difference of that, and then we have our oncotic pressure, or our colloid osmotic pressure, all right? The blood one has the amount of pull that the proteins in the blood are going to exert on the fluid outside of the blood vessels. And then the other one here, the interstitial fluid pressure, is going to be the amount of pull that the proteins in the interstitial fluid or in the tissues are exerting on the fluid inside the blood vessels. Both these latter values, this one and this one, are pretty small in a normal situation. Okay, there's a pathology involved, and that changes. Okay. All right. So what we do is we take the net hydrostatic pressure. How do we do that? We just take the difference of the pressure, all right, of the hydrostatic pressure from the inside the vessel and outside the vessel, and then we subtract the oncotic or the osmotic, the colloid osmotic pressure, all right, from that hydrostatic pressure. And there's two values that we use to determine the colloid osmotic pressure. Okay. So here's the scenario as we're looking, what does this mean for our capillary, okay? As we move along the length of the capillary, as we go from the arterial end to the venous end, okay, we're going to see this pressure drop. So at the arterial end, all right, the net filtration pressure will be higher. So that makes sense though. We want it to be higher because we want the stuff in the blood to get out into the tissue near the arterial end. Remember, so think about it, that's how we're dropping off our nutrients, our oxygen, all right, our glucose, our fatty acids, some of our hormones. We're getting it out of the blood and getting it into the tissue. But remember, all right, metabolically active cells also are going to produce waste, carbon dioxide, urea. We got to pick up the trash, right? We just dropped off the groceries, but now we have to pick up the trash. So at the venous end of the capillary, okay, we have to absorb all the wastes, all the trash. So at the arterial end, all right, the net filtration pressure is going to favor filtration. What's that mean? Okay, that means our blood vessel is going to be pushing stuff out. Okay, good. Let's get rid of glucose. Let's get rid of fatty acids. Let's get rid of all those ions that these cells need. Okay. Then as we get to the end of that capillary, we get close to the venule, then we're going to pick up the trash. Okay? What's that mean? All right, that means, all right, all the stuff that was in the tissues is going to get dumped into the capillary and go back into our venous circulation, deoxygenated blood, all that stuff. Okay? Then we're going to circulate it through the circulatory system, make it to the kidneys, filter out some of that stuff. Okay? So arterial end favors filtration. Venous end favors resorption. We good with that? I'll show you a good picture. This is in your book. All right, figure 2010. Okay, and that's what this is showing us here. Okay, so here comes our blood from the heart. Lovely, lovely, delicious oxygenated blood that's rich in all the nutrients and all the good stuff. Okay, here on the arterial end, okay, you can see, all right, our hydrostatic pressure. All right, the net hydrostatic pressure. All right, the hydrostatic pressure for the blood is 35 millimeters of mercury, and then we can see there's no pressure from the tissues. So that's 35 millimeters of mercury for the hydrostatic pressure. Then we're looking at the net colloid osmotic pressure. All right, the pressure inside is 26 millimeters of mercury. That's the pulling force. And then you have the pulling force inside the vessel. Then you have the pulling force outside the vessel. All right, we take the difference of that. All right, 26 minus 5 is 21. 35 minus 21 is a net of 14. That means it favors, since it's positive, it favors the pushing out of stuff from the blood vessels. Now, as we go towards the venous end of our capillary, all right, the net hydrostatic pressure has dropped now. Now it's only 60 millimeters of mercury. All right, same hydrostatic pressure for the interstitial fluid, still 0. So now it's 60 millimeters of mercury minus, all right, 21 millimeters of mercury from the oncotic pressure. That's a negative value that favors reabsorption. That means that fluid is being pulled in or drawn into the blood vessel, which is good. We'll get the wastes that way. We'll get the respiratory gases of carbon dioxide. And then we'll dump it into the venous blood and return to the heart. We'll take it off that way. We'll talk about the lymphatic system more on this, but not all the fluid that gets pushed out of the blood vessel gets returned to the blood vessel. All right, no problem. We got the lymphatic circulatory system for that. All right, it will pick up some of that fluid that didn't make it back into the capillary. Okay, so we really see the lymphatic system play a significant role in situations of like a sprained ankle, for example. You know, all that swelling you get down in that ankle. All right, circulatory system does a good job in getting a decent amount of that inflammation back into circulation, but the lymphatic system helps, all right, because it helps with that resorption there. And that's okay, because guess what? The lymphatic system eventually drains back into the circulatory system. Okay, so it's all going to get returned back to the blood anyways. Then it gets filtered through the spleen and the kidneys and the liver, all right? And so we have ways to handle that, okay? But we will eventually dump everything from the lymphatic system back into our venous circulation there, which is good, okay? It's better to have, you know, many hands on board and helping cleaning up the mess here. Okay, so the next part that I want to talk to you folks about is going to be about the concept of blood flow, okay? There's two types of blood flow. There's local blood flow and systemic blood flow. We're going to start off with local blood flow, okay? Basically, what happens with the capillaries, okay? So when we talk about blood flow locally, all right, again, we're going to use a volume measurement, so in this case millimeters, and then how much occurs in a minute, okay? So how much blood is going to flow into a certain area, all right, within a minute, all right? So what we want to see is, remember, if you remember what, do you folks remember what perfusion is? Perfusion is when, you know, the blood actually saturates an area of tissue, okay? So when you hear that term perfusion, Just think of you spill a drink, all right, and you wipe it up with a paper towel, and that paper towel gets soaking wet. That paper towel is now perfused with whatever that you were drinking, all right? Think of the paper towel as the tissue, okay? So that's what we're talking about here when we're talking about blood flow. We want to perfuse that tissue with enough of a volume of blood to satisfy the metabolic requirements of that tissue, okay? Because if we don't, that tissue could die, all right, or become damaged, all right? So when we talk about local blood flow, we're going to look at these four, all right, characteristics or areas, all right? How much of that tissue has a vascular supply or the degree of vascularity, all right? Myogenic, myo is muscle. So what role is smooth muscle going to play, all right, for local tissue perfusion, all right? What are some of the other regulatory factors that are going to affect blood flow? What chemicals are we going to involve? We're going to get something that's going to vasodilate a blood vessel or get something that's going to vasoconstrict. And then finally, we'll get into total blood flow. All right, and we're going to talk about a couple issues with that. Okay? So let's start off with something easy, and we'll start off with the degree of tissue vascularity. Right? We learned when we were talking about connective tissue, for example. Some connective tissue, all right, is highly vascularized. Mature cartilage is avascular. There's no blood going to that. Okay? Bone, another type of connective tissue, is highly vascularized. Okay? So let's talk about, all right, the degree of tissue vascularity and what effect it has, all right, on perfusion. Okay? So when we talk about vascularization, certain tissues that are metabolically active, that do a lot of stuff, okay? Skeletal muscle is a great example, right? You ever seen a bodybuilder that works out or an endurance athlete that is working out really hard, all right? You'll see blood vessels just all throughout their skeletal muscle. You'll see it in those professional bodybuilders. All, you know, for some people it can be pretty nasty. There's this one guy that works out in my gym. I think it's nasty. He's just got so many veins. I know I shouldn't be looking at him. I should be focusing on myself. But I just noticed those things. And it just tells me that this person is engaging in enough activity that they've increased their vascularity. Okay? So when their tissues have a certain demand, all right, they need to have, all right, nutrients to satisfy the metabolic processes, all right, they're going to grow new blood vessels. And we refer to that as angiogenesis. Okay? That's the formation of new blood vessels. So we're going to see how this formation of these new blood vessels, and it only makes sense because if the tissue demands increase, all right, for skeletal muscle, for the liver, even for the heart, all right, you'll see some anastomoses, not a significant amount, but enough that it has to satisfy, all right, especially when the heart hypertrophies, if the person's a big endurance athlete, all right, they are going to increase, all right, the formation of the new blood vessels, so we call that angiogenesis, okay? And it takes a little bit of time because we have to build the blood vessels. It's just like building new roadways. It takes a little bit of time, all right? But our end goal is to this, increase perfusion. We need to increase perfusion. We need to bathe that tissue in blood so it gets its nutrients, so it can get rid of its wastes. Okay? So the person that works out a lot, increase in skeletal muscle. The person that sits around and doesn't do much, they'll increase adipose tissue. Well, guess what? Adipose tissue is loose connective tissue. Loose connective tissue has a high amount of vascularity. Think of adipose tissue as energy. Energy just waiting to be used, and that's what your body's doing. It's a genetic survival mechanism in our bodies. Our bodies don't want to waste fat, so guess what? It's going to build up fat. You don't use the meal that you just ate, no problem. Your body's like, I'm going to store that for later, for a rainy day. And so it needs to be able to access that energy, those triglycerides, right? And it does so by the creation of new blood vessels.
So you're saying, like, if you're obese, you have more blood vessels.
Yep, isn't that crazy? Yeah, yeah. Because again, your body doesn't know. It just knows, through survival mechanisms that I need this energy. You keep putting food in me, so I'm going to store it. This is what you want. It's not what I want, but that's what your body thinks. So it's just going to fill up those adipocytes with more and more and more lipids.
When people have the gastric bypass or whatever to lose the weight, do they lose those blood vessels?
Girl, I must have paid you money to ask me that question because we're going to see it right here in this next slide. That concept is called regression. Yes, and that's what will happen. And they also have to be careful with that too, because with blood pressure issues too, because you've now changed and we'll get into this too, about the total peripheral resistance and whatnot. So that leads me into the next thing, and that's a huge concern when someone has a gastric bypass surgery or the gastric sleeve. When they start to lose weight, they have to do it gradually, because if you do it all at once, right, that blood volume that you had, some people that are large could have 5.5, close to 6 liters of blood, right, because it has to circulate and perfuse to all those tissues. So now we need to lower that down. So their blood pressure will start to drop. If it drops too quickly and too fast, well, you know what happens when your blood pressure drops. You pass out, all right? So there's issues with that. We'll jump into that. But that leads me into regression, all right? So now, that saying, what goes up must come down. So now what we'll see is, all right, now that person stops working out, okay, the skeletal muscle no longer needs all that the blood vessels that used to supply it, so they'll start to regress. Those new blood vessels will start to disappear. And the same thing in somebody with the adipose tissue, if they lose a lot of weight, all right, again, we don't need that tissue. When I say the tissue, we don't need those blood vessels there because the adipose tissue has since decreased. All right, so we'll go back to the original or previous state of the blood vessels. Okay, it's like that saying, if you don't use it, you lose it. Okay, so if you're not using all that adipose tissue and you start to lose it, then there's no need for those blood vessels to supply the adipocytes. Okay, so they go away.
How do they go away?
Pardon? Takes a while. It's just like with anything, like with atrophy, if you don't exercise the skeletal muscle, you'll start to lose the proteins, the actin myosin proteins. They just start to degrade, and then you'll have fewer cross bridges. The muscle starts to get smaller. Same thing here. Because basically adipocytes it varies, and we'll talk more about this when we get to metabolism. But adipocytes, when they're full, they swell up because we just loaded it up with lipids. Right, depending on what your energy state is. If you're in a low energy state, meaning you don't need much energy, it uses up those lipids and they kind of deflate the cell. I'll show you some pictures when we get to metabolism there, but we'll talk about that. That's why I love this 211. We get to talk about all this cool stuff. It's all out there. So this brings me into tumors, okay? And there's a lot of research into cancers. All right, when we talk about tumor angiogenesis. This is one of those things that's really it's problematic. As we know, when we talk about cancer, neoplasia, new uncontrolled growth, tumor cells are just abnormal cells that are growing out of control, but they have needs too. All right, and those needs require energy, and they're still going to metabolize things. So they need to get supplies. All right, so in situations like this, these tumor cells are clever. They start to produce these growth factors. These are just chemicals. And when your body is exposed to these chemicals, it just responds by whatever those chemicals are telling them to do. And so guess what? It will build, all right, more, all right, blood vessels. So now those tumor cells aren't starved anymore, okay? Because that's a possibility. They could get starved because the body, if the body realizes what's going on, all right, you'll get white blood cells that will go to work on these, all right, cells. But at the same time, another way to starve a tumor is to cut off its blood supply. Okay? Well, these tumors are smart. They start to produce these growth factors, and these growth factors cause angiogenesis. So we're starting to look into, all right, research drugs that decrease the growth factors, which will stymie or slow down or halt new blood vessel growth, especially to neoplasia. Okay, so that's the first one, the first category when we were talking about, all right, where was I? All right, the degree of tissue vascularity. Now let's talk about what muscles are going to do. Okay, muscles. The myogenic response, myo being muscle. And in this case, we're going to talk about smooth muscles. Well, we know what the smooth muscles are involved. All right, they're found in the tunica media, which is inside the vessel wall, helps with vasoconstriction and vasorelaxation. And then when we get down to the capillaries and whatnot, they're around what we call the sphincter areas, and they'll contract and they'll decrease blood flow to those areas there. So the myogenic response, the whole idea or the whole concept is to keep blood flow constant. We don't want it to ebb and flow, you know, not herky. Do you want to ride in a car with somebody that keeps putting on the brake and then putting on the accelerator? Herky jerky, no way. You know, we want a nice smooth ride, and that's what these guys do, okay? So when we talk about blood pressure, all right, if our systemic blood pressure increases, all right, initially, there'll be a stretch on the blood vessel wall, okay? Pus it out a little bit initially. So we get a stretch because blood pressure is increased, all right? And so the smooth muscles are going to respond to that by contracting, okay? And that contraction will then return blood pressure to the normal levels, okay? That is our myogenic response initially. All right, depending on what we'll get into some of the other stuff, but initially what will happen, get a quick spike in your blood pressure. All right, you take a quick sprint, your blood pressure increases because your heart rate will run up. All right, when that first occurs, all right, we get this myogenic response, all right, where we get a little bit of vasoconstriction. Boom, shut it down just a little bit, and then we'll allow that vasoconstriction, that contraction there, will allow our local flow to the original levels. Local. Not talking about systemic, but local, to the tissue. Okay? Now, if our blood pressure drops, okay, real quick, we'll see a decrease in the stretch on the vessel walls. So initially, all right, we'll get vasodilation. The smooth muscle will relax. Okay? And then that will then allow the blood pressure, local flow to that area to go back to the normal levels. Remember, we always want to keep blood flow locally constant. Constant. That's the goal. We want to keep it constant so our perfusion rate is constant. And it varies depending on what type of tissue we're dealing with. Okay? Your ligaments and tendons don't really care too much because they're close to being avascular, so they're not going to have a high level of vascularity. All right, but those tissues that are highly vascularized, this plays a huge role with that. Okay? So this is the myogenic response, so keep that in mind. So we're dealing with systemic blood pressure, all right, what effect it has at the local level or the local flow level. Okay. So now we're going to talk about how we are going to regulate local flow, right, through some chemicals. So what is going to actually determine, all right, the need for blood, for that blood flow? Well, what tissues are metabolically undergoing? What are they doing? All right? If they're constantly producing proteins, if it's skeletal muscle, which is being contracted and relaxed, all right, then we need to actually make sure that we're supplying enough blood for those metabolic needs. If it's damaged, you better believe we need to get blood there because we need to repair that damage. We need to get white blood cells, leukocytes, into that area to repair any damage, all right? So it is on a need basis. All right, when we talk about local regulation of blood flow, it is on a need basis. So what's going on? Okay, so we're going to do this with some chemicals. Okay, so we have two classifications of chemicals. We got vasodilators, which makes the lumen, here's your blood vessel. All right, the inside is the lumen. I think we all know that, right? I hope so. Okay, the lumen is the inside space. And that's where the blood flows. Okay, so we have vasodilators, which will increase the lumen, and we have vasoconstrictors that will decrease the lumen. Okay? But when we talk about, we talk about the arterioles, all right, these vasodilators will dilate the arterioles, increasing the flow there, all right, and they'll also relax. Remember the pre-capillary sphincter? If you don't, I'll show you one. Well, it doesn't have it on this drawing. A pre-capillary sphincter is going to be a smooth muscle cell that sits right here. So it can squeeze that off, okay? So it controls that. I showed you that. I don't think it was in the lab one.
So what would metabolic activity look like?
Well, pick a tissue. Well, let's do, well, I keep using skeletal muscle. Let's use the brain. Let's use nervous tissue. Perfect example. What causes 2/3 of the energy expenditure for a neuron? There's one specific protein, a transport protein, that undergoes 2/3 of the total expenditure of a neuron. Y'all remember? Chapter 12. Sodium potassium ion pump. That thing's always going. It's always going. All right. So things like that. Leak channel, well, not leak channels, take that back. Active processes. So the sodium, potassium ion pump, calcium pumps, those are one example. If we're producing proteins, beta cells in the pancreas, making things, all sorts, that's going to be metabolic needs. Yeah. I mean, I don't want to keep using.
All that, like, when all that's happening, that's when you put the local short-term regulation, and it's based on the need when the metabolic activity changes. So, like, if it lowers, then that's when it's going to come into effect, right? Or if it increases.
When you say it being the systemic blood pressure, is that what you're referring to? Yeah. Initially, it's going to be the myogenic response first off the bat. Like when you go, like I said, when you go for a quick sprint, your blood pressure shoots up initially because your heart rate increases. The systemic blood pressure increases, puts more stretch on the vessel wall. So its first response is going to be to vasodilate. Exactly. Exactly. Yeah. Yeah. Okay. Where was I? Okay, so that's vasodilators. Dilate arterioles, relax the pre-capillary sphincter. What does that do? That increases blood flow to the capillary beds. Okay? Remember, capillary beds are the exchange sites. That's where you're going to get the exchange of nutrients into the tissues, and that's where the tissues are going to exchange and give the circulation, the blood, the waste products. Okay? Dropping off the groceries, picking up the trash. All right? That's what the capillary beds are going to be known for. That's the exchange site. So our vasoconstrictors then are going to constrict the arterioles, and then it's also going to cause the pre-capillary sphincters to contract. All right? So that's going to decrease blood flow into the capillary beds. All right? So again, we'll see that, all right, when we want to shunt blood away from certain areas because we might need it somewhere else. Perfect example. When you eat, all right, a lot of the blood is going to be shunted towards your digestive system, which makes sense. As you're digesting materials, we got to get it in the blood, and it's got to get circulated throughout the body, all right? But what will happen, though, if you eat a meal, then you decide to go for a run, all right, now you're involving your skeletal muscle system, and now blood will be shunted away from the digestive system and go towards the skeletal system. So these capillary beds here, all right, in the digestive system, the arterioles are going to vasoconstrict, and the pre-capillary sphincters will pinch off. You'll get decreased blood flow there. You'll still have blood flowing there, but we're shunting that blood to your skeletal muscle system for that activity.
So is that a good thing or a bad thing then? Because if the blood
Well, it's good and bad. It's good in the fact that the sympathetic nervous system, it's a fight or flight kind of, survival mechanism. You need, because who knows, are you deciding to run because a tiger's chasing you or whatever? Yeah, yeah. So it depends, but is it great for digestion? You're not going to be maximizing the digestion there. You're still going to be breaking down the contents and whatnot, but the blood flow is going to just be decreased. You're just not going to be maximizing it. Yeah. Okay, so we got this concept of autoregulation, okay? And autoregulation, all right, is going to be, and if you look at the term auto, so you're going to think of something that's going to automatically occur, all right, this is when we have a fluctuating or changing metabolic activity occurring. And we're going to involve our negative feedback system when we're dealing with autoregulation. So for example, kind of like what we just said here, okay, when activity increases, all right, so when activity increases, all right, we are going to then try to increase perfusion. So to do that, all right, we need to have our vasodilators get involved because we want to increase blood flow to that area. Skeletal muscles again, when you're going to exercise, you're being chased by that tiger, all right? So now what we're going to see is, all right, the actual situation in which oxygen and nutrient levels decline, all right, the fact that those levels start to decline will cause, that's the stimuli. Remember, this is, we're dealing with that whole reflex phenomena. Stimuli, receptor, all right, control center, effector, okay? So the stimuli was, we have a decline in oxygen and nutrient levels, low glucose levels, oxygen is low, all right, in those tissues. Well, they will start to release, all right, chemicals that will act as vasodilators, because what's that going to do? That's going to increase the blood flow to that area. What will that do? That will increase perfusion. Okay, we've increased our perfusion. And so when that occurs, all right, we're dealing now with the negative feedback scenario. Perfusion increases, okay, and then, all right, once the blood levels and that tissue gets to that perfused saturation level when things are okay, all right, then we constrict the blood vessels and slow down the blood flow.
So if your negative feedback doesn't trigger, then, I mean, will your blood just over consume that one part?
It can, I mean, it depends. I mean, there's other systems in place that will, I mean, you'd have to have a lot of systems fail for you not to be able to decrease the perfusion. But I mean, that is a possibility, but it would take a lot, because eventually what's going to happen is you're not going to have the vasodilators being effective anymore, because oxygen levels will increase, carbon dioxide levels will decrease, so we'll get rid of the stimuli in another way, and then the negative feedback system won't be as important. So all of these, I know I got a lot of drawings here. All of these will act as vasodilators. Low oxygen, low nutrients, increased carbon dioxide, lactic acid. All right, lactic acid is a byproduct of anaerobic cellular respiration. If you don't have oxygen, you're going to get lactic acid. Hydrogen, all right? We'll talk about the importance of hydrogen. Remember hydrogen ion, pH, remember? Chapter 2, I know it was a while ago, but that's going to be pH concentration. All right, and then potassium levels. Okay, so if you ever, and I'm sure all of us have experienced reactive hyperemia at one point. The example here is walking into a warm room, especially like today, when it was a little bit chilly outside and coming in from outside. When you walk into a warm room when you were just outside, it used to happen to me all the time when I was living up north, because it was like -6 degrees around this time of year, and you would walk inside from shoveling the snow, and my face would be bright red. And the reason why is because of this reactive hyperemia, my blood flow, my local blood flow to my cutaneous structures, all right, increased significantly. All right, and so what had happened was my oxygen and nutrient levels had decreased, all right, so much, all right, but when I got into a warm environment, what happens in a warm environment? Vasodilation occurs, more blood flow to your skin, and that flushes out the system. A lot of massage therapists will use a similar flushing mechanism. When we call it contrast therapy. I'll do it on patients in which I use hot and cold packs. Have you ever had a doctor or somebody say, or a trainer say, use a heat pack first and then follow it up with a cold pack because it'll flush out the system? That's what it is. It's reactive hyperemia, because what you're doing is you're just changing, all right, the lumen of the blood vessels, going from a vasodilation to a vasoconstriction, and you're altering the blood flow. You can see if you just hold down your thumb for about 30 seconds and then release it, it'll go immediately to a bright red and then it'll go back to its normal color. That's that hyperactive, that hyperemia, I should say, in which it flushes things out. Okay. One more thing for the short-term local regulation here, and this is going to deal with tissue damage, okay? Or people forget that inflammation is not necessarily a bad thing. Long-term inflammation, no bueno. It's not good. You don't want long-term inflammation, all right? Short-term inflammation, like when you cut yourself, you will get some inflammation. That's part of the healing process. So we talk about tissue damage, but we also have to talk about the defense system here. We'll get into inflammation in much more detail in later chapters, okay? But keep in mind, when we're dealing with inflammation, we're dealing with A, damaged tissue, okay? 2, leukocytes. That should have been 1. All right, damaged tissue. And then 3, all right, platelets, okay? Because the leukocytes are going to help repair the damaged tissue. Also, if there's any sign of infection or pathological agents or pathogenic agents there, it'll help to deal with that. Platelets help with the clotting, okay? All this is going to involve vasoactive chemicals, okay? Which means we're going to have chemicals that are going to be secreted, all right, by some of the cells that were damaged, by some of the cells that came on scene, but the whole point is we need to fix the problem. So the 2 popular ones here are histamine and bradykinin. And for right now, you need to know they cause vasodilation. That's good. We want to vasodilate. We want to get more blood there. We want to get more white blood cells to the area. We want to get more platelets to the area to stop any leakage of blood, any damage to the tissue there. So initially, we see that vasodilation occur, okay? So, of course, trauma, allergies, runny nose, things of that nature, all right, watery eyes, infection, exercise is also going to be, people don't understand, why am I getting inflammation when I'm exercising? All right, but you do. Every single one of you, if you've ever gone running, you're causing tissue damage, believe it or not. Not like grand, big time, but you are actually going to cause inflammation, okay? So we have vasodilation. We also need to have vasoconstrictors. So in this case, we're going to deal with, we talked about the prostaglandins and the thromboxanes when we were talking about platelets there, the last chapter. All right, when we get into infections and whatnot, we'll circle back to prostaglandins and thromboxanes. But their job is to vasoconstrict the blood vessels. Why? Prevent blood loss. Don't want to bleed out. All right, we want to decrease that blood flow. We don't want to lose what blood we have flowing through that area there. Okay, so we'll go through this. This is kind of just a little bit of an introduction into some of that material that we're going to talk about in later chapters. And I forgot to show you guys. I'll do it in a second. I wanted to kind of quickly review the schedule here. By the way, we're doing great on the schedule. We're moving at a pretty decent pace. I hope it's not too slow for you and that you're getting bored. Okay, good. Because you have a test coming up. It's next Thursday, I believe, the 25th?
23rd.
Well, okay, that's right. Lecture is the 23rd, and then lab is the 25th. Yep, all right. Because we're going to finish up. This will be done this week. Okay, so last part, when we're talking about blood flow, and then we're going to deal with total blood flow. All right, when I talk about total blood flow, we're talking about all the blood that's circulating throughout your blood vessels in your body. Okay, so we talk about the vasculature that includes, all right, both arteries, capillaries, and the veins. Okay, so easy number to remember because you already know this number, 5.25 liters per minute. That is the average cardiac output. So that's going to be your total blood flow. All right, so cardiac output is basically you're going to pump the entire circulatory volume of your blood throughout your body in 1 minute. That's pretty good. So in 1 minute, I don't know how many minutes are in a day. I know it's a lot. I can't think of the number off the top of my head. But that's how much, all right, every minute your heart is pushing, all right, all that blood throughout the body. Now, obviously, I don't even need to tell you guys this, but that number will increase when you're exercising, because going back to what we already know, if we are exercising, we are going to be increasing the metabolic demand that tissues have. And so, of course, if we're increasing the metabolic demand, then we need to increase the blood flow to that area so we can perfuse those tissues. All right? So, when we talk about blood flow or total flow, we're going to deal with the heart, our pump, and then we're going to deal with the blood vessels. All right? I guess, so to speak, the pipes of our body. Okay? So, when we talk about total flow, we're going to talk about the pumping machinery and then the pipes that the blood is going to flow through. All right, so this is now where we're going to start talking about blood pressure. Okay, so keep in mind, all right, when we talk about blood pressure, now most of the time when someone says, I'm going to take your blood pressure, they're usually referring to the arterial blood pressure. All right, because venous blood pressure is virtually zero. Okay, capillary blood pressure goes anywhere from 40 to 20 millimeters of mercury, all right, but it's usually arterial blood pressure because it's huge. Because I'm going to show you here, all right, on this picture here, all right, this graph here is showing you blood pressure, all right, pretty much from the heart all the way to the vena cava system here. All right, so this first part here you can see, all right, when we're dealing with blood pressure, we have the systolic pressure and the diastolic pressure. Systolic pressure is when the heart's contracting. Diastolic pressure is when it's relaxing. All right, so we have this other value in here, and I'll get into that in a second. It's called the MAP, the mean arterial pressure. So if you look here, all right, we're talking about the pressure, and then we're talking about the blood vessels that the blood is flowing through. So obviously we start with the aorta, and we're going to work our way down to the capillaries and then work our way to the vena cava. If you notice, there is quite a difference in the pressure when we're in the aorta, when we're in the arteries, and then as we start to get into the arterioles, it starts to decrease. Can we all agree on that? All right, so if you think about it, all right, we know when the heart contracts, blood shoots fast, all right, and then when it relaxes, it's still flowing, all right? It's like me if I'm just kind of, you know, I'm walking and then I just walk slow. I'm always moving, but when the heart's beating, it moves the blood faster. It just gives it that shove, but it's always flowing. Right? It's always in motion, unless something pathological is going on. All right, but it's always flowing. So that's what we're seeing here. But if we notice, the difference gets smaller and smaller and smaller, and then it eventually goes away. Because by the time we get into the capillaries, remember what I said? When we get to the capillaries, that's the exchange site. We don't want it to ebb and flow. We want it to be constant. It wants to be at a constant pace. All right. So by the time we get to the capillary beds, it's at a constant pace. And look here, we get to the venules, the veins. Again, still a nice constant pace. It's not pushing really fast and then letting off. Okay. And I'll explain all that. So let's start off here with the arterial blood pressure. Okay. Our arterial blood pressure, right, like I showed on that previous slide there, all right, we're going to start off by talking about the mean arterial pressure, or the MAP. And basically, it's an average, okay? And we're going to actually take an average across the cardiac cycle, all right? And then we're going to set a value to it. So when we talk about the mean arterial pressure, here is the equation for it. Diastolic pressure plus 1/3 of the pulse pressure. Pulse pressure, okay? Pulse pressure, all right, is equal to pulse pressure is the difference between, I didn't even spell it. Did I spell that right? No, I didn't spell that right. Anyways, pulse pressure is the difference between systolic pressure and diastolic pressure. Actually, this should be, hold on. I'm going to do it. I should do it right. There we go. Okay, so pulse pressure is the diastolic pressure minus the systolic pressure. Okay, so it's the difference. So if our blood pressure on average is, is 120 over 80, okay, let's take the difference of 120 over 80, that's 40. That's where this number comes from. Okay, and then 1/3 of 40 is like 13.3, something, something, something. So add 13 to 80, and that's where 93 comes from. You guys see that? Okay. So we know what our diastolic is, okay, because if our blood pressure is 120 over 80, so there's our 80 value for diastolic pressure, and then we just take 1/3 of the pulse pressure, which is the difference between the systolic and the diastolic, which is 40. And then we just divide 40 by 3, which is 13 point something, drop the decimal, just go with 13, add that, that's 93. So this gives us a pretty good idea of tissue perfusion. And if it's above 60, that's pretty good. If it starts to fall below 60, that's not good. It means we're not perfusing, okay? Just gives us a good idea as to what's going on, okay? So that's our mean arterial pressure. And again, if we go back to the previous slide here, we'll see, all right, that pressure is going to start to drop the further we get away from the heart. Okay, blood vessels get smaller, okay? So our mean arterial pressure starts to decrease. So does our overall pressure just in general, okay?
So on that, that thing you just said, the MAP 80, I know where you got the 80 from. You got the 80 from the,
Yep.
from the bottom number. Where did you get
40
40?
is the pulse pressure is the difference. Take 120, which is the systolic, subtract diastolic from it. That'll be the 40.
Okay, hold on. What?
It's going to be the difference between the systolic value and the diastolic value. And then you're going to just divide it by 3, whatever that value is. So it's 1/3 the pulse pressure. All right, so that's going to be our arterial blood pressure. But for this point, blood pressure is highest in the arterial system. All right, I want you to walk away with anything. That's what I want you to walk away with. All right, it is highest in the arterial system. Obviously, it's going to be the highest in the aorta, because check it out. All right, you can see that huge value, that big difference here in the aorta. All right, and then obviously we get down to like the elastic arteries and whatnot. That difference starts to become smaller and smaller as the blood vessels start to get smaller and smaller. All right, and then we get to the capillary system. All right, it's still decreasing. All right, which leads me into this part. All right, so capillary blood pressure. All right, we no longer, remember what I was saying, we don't have that fluctuation anymore. Okay, so it's nice and smooth and fluid. Well, it's fluid because it's fluid there, but you know what I mean. The flow is just nice and constant. Okay, so it's not ebbing and flowing. It's just like you turn your sink on and it's just running out. And that's what we're seeing here, okay? And that's what we want, ideally, because remember what I said, the capillaries are the exchange site. We need to exchange, all right, nutrients and wastes, right, across these barriers here, okay? So the capillary pulse pressure, this is like Goldilocks and the Three Bears, you know, all right? We want it to be high enough so we can exchange our substances, but not too low, all right? Or not, flip that. We need it to be low enough for exchange of substances, all right? But not too high where we damage the blood vessels. So this goes back to that earlier topic that I was talking about, all right? When we were talking about the capillary and filtration versus resorption, all right? That net filtration rate, okay? At the arterial end, we have that value of about 40 millimeters of mercury, okay? That is going to be enough to promote that filtration, okay? That's going to push those substances out of the blood into the tissues. We get to the venous end, all right? It's going to be around 20 millimeters of mercury, okay? And that's going to promote resorption. But keep in mind, we're still decreasing the blood pressure in that structure there, right? We don't want it to be too high. Remember, our goal is, do I have it on here? No. Perfusion. Perfusion, tissue perfusion. We want to pretty much saturate that tissue with enough blood so we can get an exchange of nutrients and also get an exchange of wastes. Okay, so filtration at the arterial end, resorption at the venous end. Filtration pushes out, all right, and resorption pushes in. Or pulls in, I should say, because it's more oncotic. Okay. So as long as we know that, and that's awesome here in the capillary beds that we have that nice smooth movement of fluid or blood through the blood vessels there. Okay. That nice smooth fluid. We don't have to worry about it pushing hard or ebbing and flowing, going high then going lower. Okay. All right. One more series of blood vessels to talk about. Boom. The veins. The venous blood pressure. All right. We've heard this term before, venous return. That's the amount of blood that is going to return to the heart. Okay. But keep in mind, remember when we talked about last class, we were discussing, all right, cardiac output and all the factors that affect cardiac output, heart rate, chronotropic agents, and then stroke volume had the ionotropic agents, venous return, and then afterload. Okay, well, here's our venous return, also known as preload. Okay, this is the amount of blood that comes in, and it's highly dependent on what we call the pressure gradient. All right, the skeletal muscle pump and the respiratory pump. This is going to be cool. You're going to love this stuff. Okay, so these three things are going to affect venous return. Venous return affects stroke volume, which affects cardiac output. See how we're starting to draw things together now? Seeing the big picture? Okay. Okay. So we already saw with the capillaries that blood flow was nice and smooth. Same thing here with venous return. Not pulsatile, still smooth, but it's even lower in the veins than it is in the capillaries. Go back to this graph here. Look, here's the pressure or blood pressure here in the capillary beds. Now as we get to the venules and the veins, it's still decreasing. And by the time we get to the vena cava, it's zero. It's zero. Okay? That's the pressure of the blood. So how are we going to get blood into the heart? If the blood pressure is zero, let's find out. Aren't you excited? I am. All right. So here are the three things. The pressure gradient, always keep in mind, pressure gradient, skeletal muscle pump, and the respiratory pump. Okay? So let's start off with the skeletal muscle pump. Easy, 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 easy. All right, veins have valves. Arteries do not. Veins have valves, arteries do not. Okay, so the skeletal muscle pump is going to help get blood from our extremities to the heart. Mainly, this is more of a bigger deal with the lower extremities. Okay, but as the skeletal muscle contracts, it's going to squeeze on the blood vessel, on the vein. Okay, and that blood is going to get squeezed in a one-way direction towards the heart, because what do the valves do? What's their purpose? What's their function? That's right. You said it, girl. It prevents the backflow. That's its job. So it's not going to go away. It's not going to go back down in the vein. It's going to go one way only, and that's going to be to the heart. Okay? So when we exercise, our venous return increases because our skeletal muscles are contracting and relaxing more frequently. So we're going to see more blood get returned to the heart. That's going to increase our venous return. All right? And that's why they make a big deal about sitting on a plane to, I was going to say Alaska, to Australia, all right, because that's like a 17-hour flight. Has anyone ever flown to Alaska? Not Alaska, to Australia? And my sister has, and it's from the West Coast. It's a 17-hour flight. So the big thing is don't sit around. Get up, move around, all right? Because that blood will pool. If blood pools long enough, it has the possibility of coagulating, all right? Forming clots. We don't want that. That's bad news. So here's a picture of the skeletal muscle pump. You can see, all right, our skeletal muscles here contracting. They're squeezing the blood vessel. Well, the valve here is closed. It can't go down. It can only go up one direction, all right, to the heart. Now when it relaxes, blood moves into this area, and the same thing happens. When the muscle contracts again, it pushes it forward, ever forward. So that's one of the ways, all right, that we can get blood to return to the heart. The respiratory pump is really cool. Just by us sitting here, yeah, just by us sitting here, this one here, this one here, all right, just by us sitting here, breathing, all right, is helping facilitate that movement of blood. Because right now, none of us are really contracting our skeletal muscles. Maybe you guys are, you know, when you're typing or writing or whatnot, all right? But when we are sitting here, the fact that we're breathing is activating what we call the respiratory pump. Really cool. And again, this has to do with pressure, all right? And we get to talk more about pressure when we get into the respiratory chapter, all right? But look at it like this, all right? When we talk about inspiration and expiration, okay? That changes the pressure gradient, okay? So when you take a breath in, the diaphragm contracts. It drops down, becomes more flat, all right? But what happens is the pressure in your belly, in the abdominal area, is higher, or it increases more than the pressure in your chest or thorax. So blood is going to go from an area of high pressure to low pressure. So the blood in the abdominal veins is pushed toward the thoracic cavity because the pressure in the thoracic cavity is less than what it is in the abdomen. Then you exhale, right? And the abdomen the diaphragm relaxes. It goes back into its dome-like position here. And what happens then is that the pressure in the thoracic cavity increases, and the abdominal cavity, it decreases. So what does that mean? Well, at that point, the blood that's in your lower extremities can then move into the abdominal cavity because it's less in the abdominal cavity than it is in your legs, okay? So it moves into the abdominal cavity, all right, from the abdominal veins, but at the same time, all right, the blood that's in the thoracic cavity gets pushed into the heart. That's cool, just by breathing. Us just sitting here. So when you're sleeping, this is going on. You know, you're not moving around unless you're one of those people that violently thrashes around at night, okay? But this here allows for enhanced blood flow back into your heart, okay? It does help that you're sleeping, hopefully, horizontally, all right? So it makes it easier for blood to circulate around, okay? But a big take-home message is when you are moving around, okay, doing some physical activity, you're going to increase your respiration rate, okay? Normal respiration rate is between 12 to 20 breaths per minute, okay? So when you're exercising, it can get up into the high 20s, if not more than that. And so that's going to increase your venous return, okay? Cool stuff. I'll show you, there's a picture here in your book. Okay. So this picture is in your book, just basically telling you what I was just telling you here, okay? So inspiration, okay, the diaphragm contracts, it flattens out. Pressure in the thorax is less than the pressure in the abdominal cavity. So blood moves down the pressure gradient and moves into the thoracic cavity here. Then when you exhale, the pressure increases here in the thoracic cavity, pushing the blood, all right, in the vena cava into the heart. Meanwhile, All right, the decreased pressure in the abdominal cavity allows blood flowing here from your lower extremity veins into the abdomen there. And then it waits for the next breath. All right, last slide here. Just what is blood pressure, okay? So again, when we're dealing with blood pressure on a systemic level, all right, that's everything that I just talked about, all right? The systemic level, pretty much starting in the arteries and going to the vena cava, all right? So on that one slide there, I showed you our mean arterial pressure, the map, all right, that was about 93 millimeters of mercury, okay? And then we saw on our graph what the venous pressure was. That was virtually 0. So of course, when you're trying to figure out what the pressure gradient is, you just take the difference between the two values. Well, I think we all can figure out what that difference is. 90 minus 0 is 0, right? Ah, good, you're paying attention. Yes, 93 minus 0 is 93, all right? So that's what we're going to see here. So our blood pressure gradient is 93 millimeters of mercury, okay? Which is why, all right, you can see how blood goes from the arterial system. Here's the heart. It's not the best. I know yesterday was Valentine's Day. All right, goes into the arterial system, then goes into the capillary system, all right, and then it goes back into the venous system. All right, and that pressure gradient drives it in this direction. Okay? So we're going to get into this in the next class when we talk about total blood flow. Okay? But I really want the takeaway point being is, all right, if we increase the gradient, all right, we will have increased the cardiac output. So the more blood, all right, that the heart is pushing out. So say, and think about it. We know, all right, I'm getting a moment here. I notice that you guys are still writing down. I want to illustrate this to you. I'll try to do my best in words. If we increase that gradient, that pressure gradient, okay, we know that the pressure gradient is the difference of the arterial blood pressure and the venous blood pressure, which is virtually 0. So if we increase our blood pressure overall, we just saw 120 over 80. What happens now if I increase it like through exercise, 140 over 80? So remember how we figure out our pulse pressure? 140 minus the diastolic, which is 80, which is 60 millimeters of mercury. Take 1/3 of that, which is 20. Add that on to the diastolic, which is 100. All right, I know I'm doing math in my head. It takes a second here. All right, so our new blood pressure, all right, we started working out as 140 over 80. I'm just going to use easy math. Okay, remember our map is going to be diastolic plus 1/3 of the pulse pressure. So what's our diastolic? 80, right? So we say 80, then plus, what's 1/3 of our pulse pressure? Pulse pressure is 60. Divide that by 3. That's 20. So 20 plus 80 is 100. So we've increased, all right, by increasing our cardiac output, that's going to increase, all right, our pressure gradient here. All right, we'll talk more about this. I know you guys are probably, I went over a little bit. Let's take a break, okay, and we will get into lab stuff, okay? You folks at home, let's take a break. If you have questions, ask them in lab, because I'm about to lose you here as I shut this off.